morning, everyone. We're going to start very punctually this morning. Welcome to Journal Club, all the core sites, and if anybody is with us outside the core sites, as our first short presentation this morning, we have Dr. Elena Miller, PGY4 Geriatric Medicine Subspecialty Resident for her first Journal Club presentation. So welcome, and I will hand it over to you. I will remind all the sites to mute their microphones, please. And thank you, Elena.
Hi, thanks so much, Dr. Gandel. So the journal article that I chose is the impact of social network on the risk and consequences of injurious falls in older adults. It was published in the JAGS September 2019. I have no conflicts of interest. And the objective of the study was to examine the impact of social connections and social support on the risk of falls and fall-related functional decline and mortality. Some background: social isolation is a risk factor for dementia, depression, and mortality. The relationship between social isolation and falls has not been fully characterized. Previous studies focused on single social measures and showed contrasting results. So this study population was based on data from the Swedish National Study on Aging. They collected information at baseline and 6-year follow-up. And the information collected was falls, mortality, and severe falls. And severe falls were defined as at least one fracture or intracranial injury. There were 2,200 participants, and they were all community dwellers. Some other variables that were collected was social connections, which was defined as the size of an individual's social network, and social support, which was the perception of the availability of support and the satisfaction with contacts. Each of social connections and social support was categorized as a Z score: poor, moderate, or rich. They also created a fall risk variable, and this was a variable based on education, BMI, smoking, alcohol, cognitive status, depressive symptoms, physical performance, fall-increasing drugs, and multimorbidity. And this was characterized as either high, medium, or low in all of the participants. So the baseline characteristics, I think unsurprisingly, showed that people with rich social connections were more likely to be younger, more educated, functionally independent, have better cognitive, physical, and psychological status. So this is a bar graph of the incidence of falls. On the y-axis is the incidence rate of falls per 1,000 person years. And on the x-axis are the rich, moderate, and poor connections. On the left, it's social connections, and on the right, it's social support. And the dark blue bar graph is age and sex standardized, and the light blue is multivariable standardized. And they found that the incidence of falls was higher in people with poor or moderate social connections. The results were similar. So incidence of falls higher for people with poor or moderate social support as well. This is a table showing the hazard ratio of injurious falls, and they've used the people with rich social connections as a reference, and they found that the risk of falls was significantly associated with social connections, and it was not statistically significant relationship with social support. So with social connections, people with moderate or poor social connections were associated with a 50 and 70% higher risk of falls than those with rich social connections. This is the incidence of falls stratified according to falls risk variable. So on the y-axis, again, we have the incidence of falls. On the x-axis, we have low, medium, or high risk of falls based on their variable that they created. And the green are the rich social connections, the yellow is moderate, and the red is poor social connections. And overall, they found the incidence of falls increased with decreasing social connections and social support. They also did analysis of subset of groups, so those who had severe falls or multiple falls, and there were 187 people in this group. And the people with multiple falls and severe falls had a 3-time odds of functional decline and 2 times odds of mortality. And for those people with severe or multiple falls and poor social support, they had 2 times the odds of functional decline compared to those with rich social support. So in conclusion, social network can influence the risk and prognosis of falls in older people. So social network should be evaluated when assessing risk for falls. Maintaining or improving older person's social connections could lower fall risk, and enhancing social contacts and support may influence the risk of disability and mortality after severe or multiple falls. So in terms of the critical appraisal, there were some limitations of this study. They considered only falls that required medical attention, and they excluded individuals living in long-term care. And then limitations specifically with their fall risk variable. It was computed by assuming each risk factor contributed equally in increasing the fall risk, and it hasn't yet been validated or used in other work. Some of the strengths of this study is it's a large cohort. They did a very comprehensive social network assessment, and the data from falls was collected from national registers, which offered more reliable information on falls compared to self-reported data. So the bottom line is that this study increased awareness of the impact of social factors on increased risk of falls, and that we need more targeted intervention for this group. And that's it.
Thank you very much, Elena. Thank you very much. Very topical, considering the increased number of times loneliness and depression is making headlines. Thank you for a topical presentation. We're going to take a couple of minutes just to switch over slides, and for YY, Dr. Zhu's presentation in a moment.
Thanks, Dr. Gendel, for fixing the technical difficulties. So my name is YY. I'm one of the PGY4 residents in geriatric medicine, and today I will be discussing a recent article, is the association between blood pressure and mortality in older adults different with frailty? This was a systematic review and meta-analysis published in Age and Aging in, I believe, June or July of this year. I will note that it was collaborative between some authors in the UK, but we do have representation from Canada with Ken Rockwood. I have no conflicts of interest to disclose. So the objectives of my presentation today will be to outline the literature on blood pressure management in older adults, to review this study's methods and results, and also to provide a critical appraisal of the study and to initiate a discussion on its implications. So to start off with some background, we do know that hypertension is a very common condition in older adults, And it's estimated that about a third of adults have hypertension, and that over 3/4 of adults over the age of 80 years will have been diagnosed with hypertension. With aging, we also see various physiologic changes in blood pressure, including a gradual increase in systolic blood pressure, as well as a reduction in diastolic blood pressure, resulting in a widening of pulse pressure as we age. There's been quite robust evidence that has supported the treatment of hypertension in reducing all-cause mortality, as well as cardiovascular mortality and morbidity, along with cerebrovascular mortality and morbidity. However, there are a number of nuances to the relationship between blood pressure and these important outcomes. For example, a meta-analysis of prospective studies from 2002 suggested that the association of blood pressure and the proportional decrease in risk of vascular mortality may reduce with age. As well, given studies have shown an increase in mortality with decreasing blood pressure, there is also a hypothesized U-shaped relationship between blood pressure and mortality. On the flip side, there are various potential harms associated with treating hypertension, whether that be the very fact of lowering the blood pressure, also related to the adverse effects of the agents we use. And this includes electrolyte disturbances, acute kidney injury, orthostatic hypotension, falls, and syncope. The effect of blood pressure on cognition is a bit less clear. A relatively small cohort study found that treating blood pressure to less than 130 may accelerate progression of cognitive decline in patients with existing mild cognitive impairment or dementia. However, analysis of the larger SPRINT trial did not show any harm on cognition from intensive reduction of blood pressure to less than 120. And in fact, I believe they did find it reduced the risk of MCI. So currently, across the world, we have variable guidelines reflecting the uncertainty still regarding treatment thresholds and targets in the older adult population, particularly in those over 80 years. So starting with Canada, the Hypertension Canada's latest guidelines from 2018 suggest a target blood pressure of less than 140/90 in those without other compelling indications. However, in these guidelines, they do not specify targets based on age or frailty status. In contrast, the NICE guidelines from the UK use an age cutoff of 80 years, and they recommend targeting less than 140/90 in people younger than 80, but also recommend less than 150/90 in people 80 or older. They also specify to use clinical judgment for those with frailty and multimorbidity. And then moving to the US, the ACC/AHA guidelines published in 2017 recommend quite different systolic blood pressure of less than 130 in non-institutionalized community dwelling ambulatory adults 65 and older. They also provide a warning about the risk of adverse effects with intensive blood pressure lowering among frail patients. And then lastly, the European guidelines, the ESC/ESH guidelines from 2018 suggest targeting systolic blood pressure 130 to 139 in individuals 80 and over, if tolerated. I found this guideline had the most elaboration regarding age and frailty, as they had a specific section on special considerations in frail and older patients. They specified that treatment should never be denied or withdrawn on the basis of age alone, provided that treatment is tolerated. Again, I'd just like to summarize that the degree of variability here across different countries reflects the varying results from the different studies that we may highlight in the upcoming slides. So going back to the 1990s, there were several randomized controlled trials that showed the benefit on cardiovascular outcomes of blood pressure lowering at older ages. And then more recently, we had the hypertension in the very elderly trial, the HIVET trial, which focused on patients who were aged 80 years or older. They randomized patients to either the treatment arm with indapamide to start, and then, if necessary, perindopril to achieve a target blood pressure of less than 150/80, or they were randomized to placebo. They found that the treatment of blood pressure to target less than 150/80 was associated with a trend towards reduced rates of fatal and non-fatal stroke, and a significant reduction in the secondary outcomes of fatal stroke, all-cause mortality, and cardiovascular outcomes, including heart failure. However, one limitation of the HAVET study is the exclusion of those with dementia and those living in a nursing home, likely a population of patients that are more frail, which may limit its generalizability. And then a Cochrane review in 2009 of 15 RCTs showed a significant benefit in treating hypertension in adults age 60 and older in reducing cardiovascular and cerebrovascular morbidity and mortality. However, it was interesting that they found the benefit in all-cause mortality of lowering blood pressure was only seen in adults 60 to 80 years of age and not seen in those 80 and older. And then came along the large SPRINT trial published in 2016, which further strengthened the evidence for the benefits of lowering blood pressure to actually a more intensive degree than before studied, and also reignited the discussion around what the optimal blood pressure target is in older adults with hypertension. The data for the predefined subgroup analysis in patients aged 75 years and older was published in the SPRINT Senior study. Of note, participants in this trial were excluded if they had a diagnosis of dementia or resided in a nursing home, similar to the HAVET study. The intensive group with target systolic blood pressure less than 120 had significantly reduced cardiovascular mortality and morbidity compared to the standard group with target systolic less than 140. However, adverse events, including hypotension, syncope, electrolyte abnormalities, and kidney injury were higher, but not statistically different in the intensive group. So a systematic review and meta-analysis from 2017 looked at the outcomes of intensive blood pressure lowering in fit older patients. This meta-analysis included 4 RCTs, one of which was the SPRINT Senior trial. The other 3 trials notably defined intensive control as less than 140 rather than less than 120, and they compared to a standard blood pressure of 140 to 149 systolic. So this meta-analysis found that intensive compared to standard treatment was associated in a reduction in major adverse cardiovascular events, or MACE outcomes, cardiovascular mortality, and heart failure. There was limited data on adverse effects, but the analysis suggested an increased risk of renal failure in the more intensively treated group. Notably, none of the other trials, none of the other 3 trials in this meta-analysis, except for SPRINT Senior, evaluated frailty status. So what about frailty? There is limited evidence to guide the treatment of hypertension in frail older patients, particularly those who do not reside in a long-term care setting. We do have some secondary and subgroup analysis from the 2 trials that I have mentioned. So the HAVET trial included a secondary study of participants for whom there was frailty data. They measured frailty using a 25-item frailty index, and they found no interaction between frailty and the benefits or harms of blood pressure reduction in this analysis. So both frail and fit participants in the HAVET trial seemed to benefit from blood pressure reduction. And then in the SPRINT trial, frailty was measured using a 36-item frailty index. Over 9,000 participants were classified into 3 categories of frailty. About 18% were deemed fit, about half were less fit, and just over a quarter were frail. They found that for every 1% increase in the frailty index, there was a statistically significantly higher risk for self-reported falls, injurious falls, and all-cause hospitalizations. And then just to talk a bit about some of the other large cohort studies that have been done. So the Partage study examined the outcomes of antihypertensive therapy among patients living in long-term care. This study was a 2-year longitudinal study of 1,127 frail adults aged 80 years and older living in a long-term care setting. The study found a higher risk of all-cause mortality in patients with systolic blood pressure less than 130 taking 2 or more antihypertensive medications compared to those who were only on 1 or no medications. So given those results, the authors in this study had suggested considering in frail individuals a target of less than 150, and also suggested that hypertension should be treated with monotherapy if possible at a low dose. Some similar conclusions were drawn from this Milan Geriatric's 75+ cohort study about the harms of lowering blood pressure too intensely in older adults. So this was a 10-year longitudinal study on adults 75 years and older, this time residing in the community rather than long-term care. The study demonstrated a U-shaped relationship of systolic and diastolic blood pressure with mortality. In particular, patients with systolic blood pressure less than 120 were found to have a 1.64-fold higher mortality risk compared to those in the systolic range of 160 to 179. Moreover, higher systolic blood pressure was associated with lower mortality in patients who had impaired activities of daily living and impaired cognitive status. And in this case, it was measured with the MMSE. So after going through some of the literature on this topic, some unanswered questions remain. For example, how low should we be treating the blood pressure in older adults who are frail? And where exactly does frailty fit in the relationship between blood pressure and various clinical outcomes? So the objectives of this review and meta-analysis were to investigate whether the association between blood pressure and clinical outcomes is different in older adults with and without frailty. So given the lack of randomized controlled trial studies on this topic in this specific population, the authors decided to conduct a review for observational studies. For inclusion criteria, the study must have had community-dwelling older adults with a mean age greater than 65, have follow-up for at least 6 months, have blood pressure measurements at baseline with or without treatment using a standardized measurement, and also had to measure frailty at baseline using a measure validated as being prognostic for reduced survival in more than one study. They classified participants in terms of frailty quite dichotomously as either frail or not frail. They also excluded data if the participant was unable to complete the frailty test. So the primary outcome of interest was all-cause mortality. The planned secondary outcomes were falls, stroke, non-fatal MI, and various other outcomes listed on the slide. So the authors searched several databases from January 2000 to June 2018. They only included English language publications. They did search the reference lists of the studies they found and also searched registries for unpublished work. They contacted study authors if abstracts referred to any unpublished work to get further information. The eligibility of studies was determined by 2 independent reviewers, with any disagreements settled by consensus discussion with the 3rd reviewer. The authors extracted hazard ratios with 95% confidence intervals for time to event data, such as mortality, for different categories of baseline systolic and diastolic blood pressure, with and without frailty, adjusted for a minimum of age and sex. This data extraction was done by 2 independent reviewers, again with any disagreement settled by consensus discussion with the 3rd reviewer. So the data was synthesized by calculating natural logarithms of hazard ratios to create summary forest plots. They assessed heterogeneity among the studies using the I-squared statistic. And they used fixed effects modeling if I-squared was less than 50%, reflecting low heterogeneity, or random effects modeling if I-squared was greater than 50%, suggesting high heterogeneity. If a study used different categories for blood pressure, authors recategorized estimates according to the blood pressure targets specified in the NICE guidelines, so systolic 140 and diastolic of 90. So to evaluate the bias of the studies they included, 2 independent reviewers applied this Roban's tool, which is a validated tool for assessing the quality of observational studies. The tool looks at 6 domains, and they need to be rated as low, high, or unclear. So the 6 domains include selection of participants, confounding variables, measurement of exposure, blinding of the outcome measures, incomplete outcome data, and selective outcome reporting. So the search resulted in 105 full-text articles assessed for eligibility. About half of these were excluded due to lack of validated measure on frailty. 9 studies were ultimately included in the review. 1 of those was excluded from the meta-analysis because it was not possible to contact the authors for more information. So of the 9 prospective cohort studies included in this review, 3 were based in the United States, 5 in Europe, and 1 in China. The study periods ranged from 1989 to 2014. All studies were rated low or moderate in terms of overall risk of bias using the previously mentioned Roban's tool. The studies collectively included a total of over 20,000 participants with a mean follow-up of 6 years. The mean age was 81 years, with about 60% of the participants being female. 4 studies reported the proportion of long-term care residents who made up about a quarter of the sample in the 4 studies. Long-term care residents were excluded in 2 studies. Frailty was identified in just over a third of participants, and antihypertensive medication use was reported in half, and they noted the median annual mortality was 7%. In terms of blood pressure measurement, there was some variation in how it was measured and categorized. So 5 studies analyzed blood pressure as a continuous variable, 7 studies categorized blood pressure into groups using thresholds from various guidelines. And then spending a bit more time on how they measured frailty, as you can see, it was quite variable among the 9 studies. The most common way to measure frailty and dichotomize was using gait speed. So 4 of 5 studied used the threshold of 0.8 meters per second as the threshold. 1 study used this osteoporotic fracture index. 1 study used grip strength, but this was not further defined. And 1 other study used a combination of 3 models, this Groningen frailty index, Fried model, and Putz model. And the participants were deemed frail if they met the criteria for 1 of the 3 models. And lastly, another study used a combination of gait as well as grip strength measured with a hand dynamometer. So in terms of outcomes, all studies reported all-cause mortality, and 8 of the 9 used it as the primary outcome. Other secondary outcomes included disease-specific mortality, cardiovascular mortality, and change in cognitive function. So overall, the studies were all rated as low to moderate risk of bias using the Roban's tool. Of the 9 studies, 3 gave incomplete information on cohort recruitment, 4 had unclear measurement of exposure, and 2 studies didn't report the justification for the choice of confounding variables. In all studies, the primary outcome, mortality, was determined by robust means, either death registries or confirmation by the primary care physician. So this forest plot summarizes, synthesizes the data from 6 cohort studies and shows the pooled estimates of all-cause mortality in older people with and without frailty for systolic blood pressure less than 140 compared to greater than 140. So in the top part of the slide, we see that in non-frail individuals, a systolic blood pressure of less than 140 was associated with a lower mortality compared to systolic greater than 140, with a hazard ratio of 0.86 and I-squared statistic of 42%, representing moderate heterogeneity in subgroups without frailty. Below that, we see the pooled estimates in frail individuals, showing that a systolic blood pressure less than 140 had no association with mortality compared to systolic greater than 140. This time, the hazard ratio was 1.02, and the I-squared statistic was 0%, representing no evidence of statistical heterogeneity across studies for this subgroup of frail patients. So this forest plot similarly synthesizes the data from 5 cohort studies, but this time for diastolic blood pressure less than 90 versus greater than 90. So they found that a diastolic blood pressure less than 90 was not associated with a difference in mortality compared to diastolic blood pressure greater than 90 for those with frailty and without frailty. And then looking at the I-squared statistics, there was moderate heterogeneity for the subgroup with frailty, 52%, but not significant in the subgroup without frailty. So in terms of the pre-planned secondary outcomes, only one study reported cardiovascular specific mortality. It found that lower diastolic blood pressure was associated with increased cardiovascular disease mortality in patients over age 80 or in those with slower walking speed. Unfortunately, data was not available for the other secondary outcomes of interest that were pre-planned and listed there. So to summarize the results of this review and meta-analysis, they found that in older patients with frailty, a systolic blood pressure of less than 140 was not associated with a difference in mortality compared to systolic greater than 140. However, in patients without frailty, a systolic blood pressure less than 140 was associated with a 14% lower risk of death compared to systolic greater than 140. There was no association between diastolic blood pressure and mortality in older people overall, and this relationship didn't change when accounting for frailty. So moving on to the critical appraisal of the study, first we will assess the validity of the results, looking at the search strategy and assessment of study bias. So as discussed earlier, this was not a review and meta-analysis of randomized trials due to the lack of available RCTs done in this patient group. So the authors only included prospective observational studies, which inherently carry the higher risk of biases such as reverse causality and confounding bias, and this is a significant limitation. Next, the authors, in terms of did they describe a comprehensive and detailed search? So they did do that. They included unpublished work and contacted study authors. However, they only included English language publications, which could be missing some other relevant studies. And in terms of assessing for the study validity, they did use a validated tool, the Robans tool, to assess the quality and risk of bias for the 9 studies they reviewed. And next were the individual patient data used in the analysis. They didn't specify using individual patient data, so it's presumed that they used aggregate data from studies in their meta-analysis. So next, to evaluate whether or not the review's results are important in terms of the consistency and magnitude and precision of effect. So the heterogeneity across studies was measured by the I-squared statistic and was variable depending on which subgroup was analyzed. For example, for systolic blood pressure's effect on mortality in frail patients, there was no heterogeneity, but it was moderate in those without frailty. And then for diastolic blood pressure's effect on mortality in frail patients, there was moderate heterogeneity, but none for those without frailty. So the authors did do a sensitivity analysis to examine for some potential reasons contributing to the heterogeneity. Since high or uncertain risk of bias was identified in 4 studies with respect to measurement of exposure, the authors decided to exclude these studies. However, they found this did not change the pooled estimate significantly in any of the 4 subgroups. Exclusion of the largest study done in the United States for categorical comparisons of diastolic blood pressure did change the pooled estimate for those with frailty and for those without frailty. So in terms of the magnitude and precision of effect, they found that in non-frail adults, systolic blood pressure less than 140 was associated with a 14% lower risk of death compared to greater than 140. So the magnitude of the effect here, I would say, is relatively significant, and the confidence intervals around the hazard ratio of 0.86 are reasonable, but indicate that the effect could be as small as 4%. In frail adults, systolic blood pressure less than 140 was not associated with lower mortality compared to greater than 140, and the confidence intervals here are quite narrow. And lastly, in non-frail and frail adults, diastolic blood pressure less than 90 was not associated with lower mortality compared to greater than 90. And for these hazard ratios, the confidence intervals were significantly wider, particularly in the frail subgroup, ranging from 0.69 to 1.46. So lastly, looking in terms of the generalizability to the patients we see, I think the patient population assessed in the study is overall representative in terms of being community dwelling with some representation of long-term care patients. And the mean age was 81 years, and they found about 1/3 of their patients were frail. But one of the aspects I think to highlight that decreases the generalizability of results is the fact that the review dichotomized frailty status into frail or non-frail. And we know that we often see patients along the spectrum of frailty, and it may be difficult to apply results where they only dichotomized these individuals. So overall, the main strengths of the study were the inclusive search strategy and larger study sample that the authors felt was more representative of community dwelling older adults than those in the SPRINT and HIVEX trials. In terms of limitations, the largest one that was mentioned is the fact that they included all observational studies and not RCTs. The results therefore rest on the inherent potential biases of observational research, including confounding bias. As well, there was limited data on long-term care residents. There was also heterogeneity in diagnostic criteria for hypertension and thresholds for treatment. There was inconsistent definition and measurement of frailty across the different studies. And again, I mentioned that they dichotomized patients into frail or non-frail, despite evidence that supports frailty as a graded spectrum. Lastly, we can't be sure, given the nature of the data, that the association observed between blood pressure and mortality is not due to reverse causality, as low blood pressure may be a marker of the patient's proximity to death. So now to discuss a bit of the implications of the study's results. Although to me, it's quite plausible that frailty may be a mediator in the relationship between blood pressure and mortality, and it actually does support my intuitive thought that frailty rather than age is more important when considering blood pressure treatment targets. The results of this review, again, are limited by the observational nature of the data. So it's hard for us to make conclusions about causation, and we still cannot be fully sure whether or not blood pressure treatment in frail older adults reduces mortality or not. However, in terms of application to practice, I would generally say, in my perspective, it doesn't change the way my current practice goes with discussing an individualized approach to blood pressure management with patients and families, which invariably takes into account all the aspects of the comprehensive geriatric assessment, an important one being the frailty status. Certainly, this review does raise questions for further research, ideally to have RCT evidence on this topic and the relationship between blood pressure and other important outcomes besides mortality, such as, for example, functional independence or quality of life. As well, I think that there needs to be research on outcomes of blood pressure treatment across the spectrum of frailty, as we know that frail patients aren't a homogeneous population. So here are my references. Thank you for listening, and I'm happy to hear any questions or comments.
Thank you very much, Wai Wai.